this webinar. This is brought to you by Hematology Cancer Consortium, and want to thank all the members and members of the executive. We're also very grateful to the Society for Oncology and Hematological Malignancies, Dr. Hagop Kantarjian, for partnering with us. We're also very grateful to National Cancer Grid, whose platform we are using, and a big thank you to Dr. Pramesh for allowing us to use this. Even before we start, I want to thank all the speakers who have come on and agreed to participate in this at extremely short notice. We are very grateful to you in these unprecedented times that we are in, to learn from people and share our experiences and how, not only in the acute phase, but even going forward, how we are going to deal with these situations. We're also very grateful to Dr. Vinisha, who is actually handling this platform, and for all the work that is being done by her. I'm going to hand it over to her briefly for some housekeeping rules. I just request that, with the exception of the speakers and moderators, that everybody keep their mics on mute and their videos switched off, and that we will not have any questions for the first hour when the faculty are speaking. All the question answers will be at the very end, and we will take questions from the chat facility. So you can open out your chat box and type in your questions, and the moderators will direct the questions to the faculty members. Vinisha, can I hand over to you for any other housekeeping announcements on the platform?
Sure, sir. Good morning to all of you. So when the participants during the question answer round, in case you want to ask questions or raise your hand, when you go to the participant tab on the below of your screen, you would see a raise hand option. So participants can just click on that, and we as a host will be able to see that you would like to ask questions to the experts. That is thing. And on top of your right, you would see a speaker view and a gallery view. So speaker view is when you click on that, it will focus on a person who is speaking. And if it's a gallery view, you will be able to see everyone on the screen. And in case I would like to share, suppose people want to see the share screen and the speaker together on the screen, I'll just share my screen and give you all an idea. So if you just share your screen, so when I share my screen, on top of that, you will be seeing one notification saying you're seeing my screen, National Cancer Grid screen, and there is one option to the side. When you click that option, the last you will see is the side-by-side mode. So when you click on that, one side will be the presentation, other side you will see the speaker and entire people who are joining this meeting. So that option can also be clicked on. So that will help you to see the speaker as well as the presentation. That's it, sir.
Okay, thank you so much. And with that, I'll hand over to Manju to get the session going with the speakers. Manju?
Yeah, so just one more addition to what Vinisha said and what Vikram said. We will not allow questions in between the sessions. So we'll finish all the speakers talk, and at the end of it, we'll take the questions. Request all of you to put the questions in chat box. We'll not allow individual people to ask questions directly because we expect many more participants in the webinar. So with that, we'll begin with our first talk that's on acute myeloid leukemia. And I'll request Dr. Naval Davar, he needs no introduction, to go ahead and tell us how we should manage acute myeloid leukemia in this setting now as well as later, because this is something which is going to continue for several months to come. Naval, over to you.
Okay, all right. Thank you very much, Manju and Vikram, and pleasure to be able to present here. So hopefully you're able to see my slides now well.
Clearly.
All right, great. So I'm going to be talking about, general guidelines.
Naval, can you go to screen mode on your presentation? Full screen mode?
Oh, full screen mode. Yeah, I should be able to. What do I do? Let's see.
Now we'll go to the slideshow.
Yeah. Did you get it?
Yeah. Yeah. Perfect.
Okay. Perfect. Yeah. Okay. So I'll be talking about the general kind of guidelines, that we're approaching for the management of acute myeloid leukemia and MDS, with the caveat that I'm not a infectious disease or COVID expert, and there's very little real world data either published or aggregated on how to manage these scenarios. So a lot of this we are learning as we go on the job and, trying to do our best efforts to minimize potential infections. by using more novel approaches when appropriate. So, as I said, there's no specific recommendations at this time. One of the interesting things, we have been in touch with a lot of colleagues from Europe, as well as others in the United States, especially New York and the Washington State area. And it's quite interesting that the number of documented cases of patients who have AML and MDS with COVID is quite small, less than I think what we had expected. Now, we don't know if this is because this patient population, at least in our experience, is one that is always very, very cautious. They, even before COVID, tend to minimize contact, take a lot of precautions, use a lot of isolation. And so we don't know if that's what they're benefiting from, or we don't know if it's just because there are not as many acute leukemics on treatment at a given time. Either they get treated and they're in remission, they're cured, or they may not have survived as compared to a lot of the chronic leukemias where over time the prevalence is quite high for myelofibrosis, CLL. So there's very, very limited data really in AML patients, just the 2 or 3 patients that we have heard of in different sites who have had it. And in general, the presentation is very, very severe, as would be expected. There are now papers. There was one in Lancet Oncology in March. There's another one recently in JAMA looking at cancer patients with COVID. And these are enriched usually with solid tumor cancer patients. And even in solid tumor cancer patients who have completed their planned chemoradiation surgery, the incidence, even in maintenance 3 to 6 months out from their last intervention, the mortality could be in the range of 30 to 40% is what those small publications, 18 and 20 patients each, are showing. So the point is, of course, we are very, very concerned, and we are really trying to do as much as we can to try to maintain social distancing, isolation, minimize visits to the hospital for our leukemia patients, whether these are acute or chronic, because we feel that the outcome could be quite severe, especially if they're on active therapy. So I'll split it up, in 3 different groups. So patients who have completed their planned therapy. So these are people with AML who got their planned induction, consolidation, whatever the induction may have been, 3+7, flag IDA, other induction therapies, finished their 3 or 4 consolidations, either went to transplant or are on maintenance without transplant. And I think those are the patients where we really are able to minimize their visits. We are able to try to do more routine visits at home. For MD Anderson, we have unique situation which some of your institutions may have, where patients travel to us from far. 70% of our population comes from outside of 100-mile radius from Houston. So for these people, we usually like to follow them directly because many of them are on clinical trials. They may have got novel therapies, but now more and more we are depending on the local physicians. And one of the things I've noticed is our number of phone calls that I'm doing with local doctors and patients is significantly much more. But actually, it is something that can be done. And we've had so far quite good success, even in some of the trials, being able to ship medications, coordinate with local doctor, get their note and labs. And in fact, our IRB and the FDA are allowing us to use that information as a surrogate for even some of the oral trial medications. So this may even help us post-COVID, where we may be able to do more and more monitoring with the help of local doctors if they're willing to continue to partner with us and not require as much travel. We will see. Oral options we are preferring. In general, we have had good fortune in the AML in the last 3 years with the number of oral therapies, IDH1, IDH2 inhibitor, midostaurin, FLT3 inhibitor, gilteritinib, FLT3 inhibitor, and then of course venetoclax. So we are trying to move people to oral therapies as maintenance, post-transplant, post-consolidation as much as possible. So of course, the big group is the people who want us to have to start new therapy. And this is something we have discussed intensely in our group. We continue to get new diagnosis patients with AML and ALL. The numbers are definitely much smaller. I think not because we have actually closed any of our frontline trials or not accepting, it's because patients don't want to travel. And actually, the travel modalities themselves have gone down. Many flights have shut down. It's difficult to cross borders. Isolation is required, etc. But we still are getting a few patients a week. And we have decided, especially for AML, where we know that even a delay of 10 to 15 days could result in a significant negative impact or outcomes, that we will try to treat these people as we do for any newly diagnosed acute myeloid leukemia, meaning they will proceed with therapy without delay, because we feel that the risk benefit of delaying versus the 1 or 2% potential incidence of getting COVID, the risk is higher of delaying therapy. So we are not delaying therapy. The one thing we are doing, and I know many institutions we have spoken to, if they have availability, are trying to do this, is to do COVID-19 testing prior to induction. One would say, what will you do with this? So if somebody is positive, I think then we would really be taking a close look at whether we want to do induction therapy, and most likely we would probably avoid a true induction, a cytarabine anthracycline induction, maybe prefer either low intensity therapy, hypomethylating agent, hypomethylating venetoclax, or maybe even observe that patient for 1 or 2 weeks until hopefully they become negative. We have not had this scenario. We do test all our patients before they start induction, whether it's for AML or for ALL that Ellie will talk about, or for CAR T cells that Nitin may talk about. And we're doing it across the board. Even for their consolidation, we're checking it before their consolidation. And then, of course, for transplant, the transplant team is checking it before they proceed to transplant. And if it's positive, they're deferring transplant at least 2 to 3 weeks until people are out of the active window. One group where things may be shifting a little bit more quickly, which may turn out eventually to be a good finding in the research arena, is for patients above 65, above 70 for sure. We were always moving towards HMA-based therapies. Recent frontline HMA venetoclax phase 3 data has come out a few weeks ago. It shows that HMA venetoclax did meet its primary endpoint in the phase 3, beat HMA. It's already approved based on the phase 2. So that has now become a consolidated regimen for older people, definitely above 70, a lot of them above 65. But I think now with the COVID, we are moving that bar. We're definitely giving it to people above 60, even those who may be borderline, where one may argue, well, he's kind of fit and I may consider intensive. With the COVID situation, we're going for HMA-VEN because we think that that is almost equally effective, but probably less chances of major COVID if one were exposed. And even for younger patients who have high variant allele frequency TP53 or very complex cytogenetics, some of our recent analyses are showing that HMA-VEN or HMA alone may actually be equivalent to induction. So for those patients, we are starting to consider more and more, and I think this would have happened irrespective of COVID in the next few months, but we're probably accelerating it, HMA-based therapies, either HMA alone, HMA-VEN, or some of the new drugs that seem to work against TP53 that we have in trials, like APR CD47. So that's probably one of the shifts that will give us nice data that may actually help us decide in the future, irrespective of COVID, whether induction is needed in these subsets or not. The other group is patients who are on active therapy. So, if they're on active therapy, we are continuing the standard approach, induction, consolidation, for transplant in the first remission, or patients in frontline treatment are continuing as planned. Our transplant team is not delaying or deferring those. In the relapse patients, our transplant group historically has been quite aggressive. They are now doing it more in patients who have MRD negativity or very young, basically those who have an expected 25 to 35% or more chance of 3-year survival. So the very high risk, second salvage, second transplant, MRD positive, early relapses, they are trying to avoid or defer transplant. The other thing we are doing is using oral therapies. We do have trials with novel combos, or not really novel anymore because these are approved, FLT3 inhibitors like gilteritinib with venetoclax, IDH1, IDH2 with venetoclax. And I've had emails from some of our colleagues in New York actually who have wanted to know the dosing on these regimens, because we presented some of the data at ASH EHA, but the full publications are not yet out. And I know they are starting to use these as well. We don't know if these will be as optimal as the traditional frontline, but they are oral, they minimize travel, and at least they can buy patients 2 to 3 months. And in fact, they may turn out to be equivalently effective. We will see as those data aggregate. And then that's really it. We have not had any positive AML patient, thankfully, and we hope it will stay that way. There have been some CLL and myelofibrosis patients that we have had, and I think Nitin may talk about some of those. There is a large effort, and some of you who may be working with ASH has a registry to collect all the COVID positive patients. So, it may be good to go online and see if you do encounter such patients. They want some basic demographic data, which will help us in the next 3 to 4 months to aggregate more information. Okay, I will stop there. Thank you very much. I have to unshare.
Okay.
So next is Ellie.
Okay, but just.
I'm sorry. I'm next speaker is Elias. Thank you, Naval. I'm so sorry. Elias, can you share your screen, please?
Of course. Okay.
Okay. If you could go to full screen mode, then you could start.
Okay.
Okay,
Well,
perfect.
good morning, everybody. I know it's morning in India and it's night here. It's a pleasure to be here. I'm thankful for the invitation and to my colleagues in Houston as well to ask me to participate with this event. I'm sorry, I was confused. I thought it's tomorrow evening, my time. But anyway, here we are. Leukemia in the time of COVID-19. I must say there's no, as Naval mentioned, there's no data. We don't have acute leukemia patient today, fortunately, who were diagnosed with the COVID-19 infection. Therefore, what I want to share with you is our thought and recommendations if we have a patient, how we handle them, and what are we doing at MD Anderson. So as you all know, we're not testing everybody. Based on what we tested, the clinical infection is really rare, up to 2% worldwide, and the mortality from the COVID infection is 1 to 5%. Essentially, most of the patients will have a mild disease or even asymptomatic. The problem, however, if we're dealing with cancer patients, most of them are very vulnerable, and therefore the mortality can be up to 30% and more. That being said, and I must share with you at MD Anderson, we still live in the insanity of COVID. We are waiting for the surge to happen, and most likely we pass the peak. But then in the USA, people are panicking. We're not treating leukemia. Go home. Don't go to the hospital even. So one should really pay attention. What is the risk of COVID infection versus restricting access to patients to specialized cancer or moving into therapies known not to be curative? I mean, when you have a disease like ALL and can be curable, you cannot allow to give pump therapy to this patient or shorten the maintenance because these patients are curable just because you want to prevent the COVID infections. So leukemia patients are really at high risk of infection for multiple reasons. And these are related to the disease by itself, the treatment we give, immunosuppressive treatment, high intensity, or patient-specific factors. In AML or NDF, median age is 65 and 70. These are patients already coming with the bad features. So we do see, for example, neutropenia, leukopenias, and these are related to the diagnosis, the leukemia by itself, and induced by the treatment. We know in CLL and ALL, in lymphoid malignancies, we have the hypogammaglobulinemia. We have a depressed immune system seen. We have DIC thrombotic events. When I give a treatment for ALL or even AML at the beginning, I have a DIC. When I give asparaginase, I may precipitate some hypercoagulation. And of course, organ dysfunction. It can be induced by the treatment by itself, by the diagnosis, acute myelomosis leukemia. They come already with kidneys infiltration. And then patient age and comorbidities. These are really factors we know clearly from the patients who were infected by COVID and had all the troubles were essentially older people. Now, each leukemia have its own risk factors for COVID. And I will cover here ALL first, and then we'll come back to CML, and I'm sure Nitin will cover the CLL, and already Naval talk about AML. In ALL, we have a myelosuppression due to the treatment by itself and the disease. We have a hypogammaglobulinemia. We have impaired B cell function due to the monoclonals we give. This patient received tons of steroid. From the treatment among the methotrexate, we can have kidney dysfunction and pulmonary toxicities, anthracyclines for the heart, and again, the thrombotic events seen with asparaginase. And we know, for example, in COVID patients, we've seen a lot of stroke happening, thrombotic events in this patient due to the COVID infection, and there was a recent publication on this. So what are we doing today? So first of all, we have to wait the treatment of a lethal acute illness requiring aggressive therapy versus limiting treatment, limiting inpatient stay, limiting the clinical visit. And we have a problem in Houston today. In the USA, we have shortage of blood components. And therefore, we're allowing patients to run on 7 hemoglobin and lower with all the complications that can be seen in somebody who's 70, 75 years and older. Now, the good thing is throughout the years, we have developed several target therapies in AML, in ALL, and of course in chronic leukemias that may allow us to deliver very effective therapy without have to give the intensity of the chemotherapy. And in our practice today, as Nabal mentioned, every patient who is candidate for intensive chemotherapy, we screen them for COVID, we do nasal swab PCR, and if somebody coming from out of town, we will repeat it a couple of times before we treat them. I must say at MD Anderson, they have what we call the imposed self-quarantine for 14 days. And of course, that is not applicable for leukemia patients. We bring them in, we test them twice. If they're negative, we treat them. And for patients coming for routine, we test them every time before they get intensive chemotherapy. So here is a summary of my algorithm for ALL treatment. In B-cell ALL, Philadelphia negative, for younger patients, 60 years and younger, we do the hyper-CVAD followed by 4 cycles, followed by blinatumomab for 4 cycles. This is induction consolidation. Now we're moving the mini hyper-CVD into this population. I will come back to the mini hyper-CVD. For 60 years and older, we do mini hyper-CVD, essentially no intracyclines, 50% reduction of the cyclophosphamide and the steroid. And of course, we reduce the RSC from 3 grams per dose to 500 milligrams. And then we reduce methotrexate from 1 gram per day to 250. And then we use inotuzumab at a low dose to avoid VODs. We do 4 courses, and then we move to blinatumomab. For patients who are 70 years and older, we essentially eliminate chemotherapy. We do very minimal chemotherapy, 2 mini hyper-CVD, and move to blina. By doing this chemotherapy, this can be done as an outpatient because you're not giving high-dose cyclophosphamide, shorten the hospital admission, and mainly no myelosuppression, and we give growth factors. Now, in patients who are MRD positive after 2 or 3 cycles, we move right away to blina or inotuzumab in the clinical trials. Now, the question of transplant here is really gray zone because we know from the BLAST trial, transplant did not help enough this patient, and therefore, in the time of COVID, I may hold on transplantation. For pH positive, we're not doing chemotherapy at all. We're doing monoclonals plus TKIs. We have a blinaponatinib, inotuzumab, bosutinib that is led by Nitin. And finally, the maintenance. Instead of giving maintenance for 3 years, we're shortening the maintenance to 12 months, and we're adding a blina and inotuzumab as part of the maintenance. The importance of such a thing is to shorten the exposure to steroid and so many drugs, less myelosuppression, and then shorten the duration of treatment. Now, we are paying particular attention to asparaginase. I'm not saying we have to remove it from in our treatment protocol from T-cell, but pay attention for thrombotic events and coagulation problems. We do recommend PEG asparaginase. We're given every 2 weeks, not the weekly asparaginase that it doesn't exist in the US market. Here, the schema of the hyper-CVAD of blinatumomab, where we give 4 cycles of hyper-CVAD, and then we move to blina, and then we have a blina part of the maintenance. You can see we reduce the intensity of the chemotherapy by 50%, and we shorten the maintenance as well. We have 34 patients treated, and so far we have a good outcome with survival at 2 years approaching 90%. Of course, still early on, but compared to the hyper-CVAD with less chemotherapy and shorter the chemotherapy, we have really a promising outcome. And now we added to the hyper-CVAD inotuzumab as well. This is CD22 antibody, where the blina is CD19, but we have not started enrolling patients. The mini hyper-CVD in blina is really exciting because here the chemotherapy is really low dose, no myelosuppression, you don't get 0 count. You give the growth factors, but the count will not nadir below 500. We do 4 cycles, and we do inotuzumab, very low dose, 0.6, 0.9 for 0.9 total for cycle 1, and 0.6 for cycle 2, and we do it fractionated in 2 cycles. Total dose will be 2.7, still below what you can get to have VODs for blinatumomab. And again, the maintenance 18 months shortened from 3 years. The results we had so far in an older population are really good. In a median of 68 and 42 are above the age of 70 with the bad features. We have a high response rate. Everybody responded by 1, and the MRD is quite impressive, 80 and 90% overall. And here the survival curve, where we have 80% overall, CRD 80%, and the survival, the median being 45 months. Now, when we look at the patients by age, we see better outcome in those who are younger. In older, we still see complications, and therefore we moved for the older, and this is a comparison with historical data, the hyper-CVD in Blina way superior than the hyper-CVAD. For 70 years and older, as I'll show you in the table, we do 2 courses of chemotherapy with the hyper-CVD in and Blina. And this way, during the COVID time, it's really good because patient will come once a week for the bag of Blina, no myelosuppression, no inpatient house, no admission to the hospital. Here the advantage of this regimen, Blina is significantly less myelosuppressive. Instead of giving full chemotherapy, we give 4 courses. And even sometimes we switch earlier after 2 cycles to avoid myelosuppression. When we give a Blina in patients who have no tumor burden, we have no cytokine syndrome, and therefore we escalate at day 4 and 5, and that will limit the hospital admissions. 1 week bag, 1 visit a week, and finally we can deepen the MRD and shorten the maintenance from 30 months to 18 months. For pH positive, this is what we've done before. Again, in the COVID time, that is not feasible. Here the data we have, where we have 5-year survival of 74%. Transplant doesn't help for these patients. The European colleagues use dasatinib and blinatumomab. So far, the results are really good with a survival at 12 months of 96%, 92%. In Houston, we're using blina and ponatinib, and here the results so far quite promising. What you see in pink are frontline patients having a CMR in a vast majority without chemotherapy at all. Therefore, this is perfect regimen for COVID high-risk period where you can deliver a treatment without to worry about hospital admission, myelosuppression, and complications. And we have an alternative, hyper-CVD, ponatinib, blina, minimal chemotherapy as well, but blina ponatinib right now has been our standard during COVID time. MRD, blina has shown to be effective with a survival of 45% at 4 years overall, and in responding 52%. I want to highlight that transplant doesn't help in first remission. You can see transplant is overlapping. Therefore, in the COVID time, if I have somebody can give a blina or inotuzumab, and I will not go for transplantation. Today in our department, indication for transplant are listed here. For pH negative, if you have an MRD negativity, if you have a poor features, yes, we go for transplant, but that can be delayed during the COVID time. If you're MRD negative and you don't have right features, then we can keep going with the blina and maintenance as I showed you before. For MRD positive patients, we're using blina or ino. And then transplant, again, controversial at this stage. In the COVID time, I will delay transplant. For T-cell, we're using venetoclax today. There's good data in ATP. Nitin is having a study with mini hyper-CVD ven. So far, good results. Again, transplant can be postponed. For pH positive, if you have a blina ponatinib CMR, we keep going with a blina and TKIs, and definitely we don't go for transplant. If a CMR is not achieved, then a blina, and transplant should be discussed in the context of, well, feasible, not feasible. Personally, I will delay transplant in a COVID time. In the relapse setting, this is the regimen we use in the front line. Again, we use in the relapse setting minimal myelosuppression, high response rate, high MRD negativity, mainly in salvage 1, and here the survival 14 months, median 2 years of 40%. Again, these patients, today we treat them because they have a potential of cure when you give them this regimen, mainly in salvage 1. At MD Anderson in the COVID time, we're taking mainly salvage 1. For salvage 2, we're selecting them because we cannot accommodate them right now. And these patients are being offered CAR T cells whenever is possible. So to conclude with the ALL talk, risk of COVID and complication should be really weighted carefully versus restricting treatment to a patient. We should be very careful not to minimize chemotherapy. We're aiming to cure these patients. Reduce patient staff exposure, less intensive chemotherapy, but effective. We're using telemedicine, as Naval mentioned, we're every day calling patients and dictating notes. Again, treatment should be individualized based on patient-related factors, toxicities, and feasibility of treatment administration. And again, we're keeping standard hygiene, hand washing, social distancing, and then, of course, wearing a mask is daily. And in Houston on Monday, we will be fined $1,000 if we're not wearing a mask. Thank you. I will stop here.
Thank you, Ellis. Thank you so much for that lucid talk and covering each and every aspect of acute lymphoblastic leukemia in these difficult times. So with that, we move on to lymphomas. And I'll request Dr. Ranjana Advani to give her views in terms of how we manage non-Hodgkin's lymphoma, as well as a bit on Hodgkin's lymphoma too, regarding their management. They have published FAQs for ASH for management of lymphomas in this particular era. So Dr. Advani, over to you.
Okay, thank you, Manju, for inviting me. Okay, wait, here we go. So can you see my screen?
Yes.
Okay, so this is actually, we had a sort of an impromptu task force, which was put together by Dr. Jane Winter, who's the upcoming president of ASH. And she polled a bunch of us, you can see lymphoma folks, to come up with some sort of a guideline as to how we manage patients. We really, I think as the previous speaker said, we haven't really seen, even in the Bay Area, we haven't had a surge like the New York folks or the Boston folks are seeing. And I personally have not had to manage any lymphoma patient with active COVID infection. So these were more like our personal biases and how we would approach in a thing. So the questions we covered for all the subtypes of lymphoma were, are we changing practice for frontline therapy? Are you changing therapies for patients who've already started treatment? Are you changing therapy to minimize visits, for example, changing to oral or less frequent regimens? Are you changing your treatment recommendations for relapse or refractory disease? And are you changing your approach to supportive care? And I've kind of, covered this without going into too many nitty-gritty of the actual protocol, focus more on the principles of what we talked about. So just starting with aggressive lymphoma, and are we changing the approach to frontline therapy? The answer is no. R-CHOP continues to be the standard of care for large cell lymphoma, and dose-adjusted EPOCH was basically indicated for double hit and primary mediastinal. So of course, it's a more toxic regimen, and in most institutions requires hospitalization. So I think centers which have the capacity to deliver this therapy on an outpatient basis are encouraging that approach. At Stanford, we cannot do this as an outpatient. We just don't have the infusion home pharmacy pump setup. So for our situation, we have to admit patients for dose-adjusted EPOCH. And because we haven't had a surge and we do have the beds and ICU support or whatever still available to us with the very robust supportive services, we can still do it. Other centers said that they were weighing the risks and benefits individually in those subtypes, and that R-CHOP with radiotherapy was an option for at least for patients with primary mediastinal lymphoma. Now, for patients with high risk of CNS involvement with aggressive lymphomas, a minimum of 2 cycles of methotrexate high dose was recommended, the timing of which must be individualized. So it's for R-CHOP, usually we do 4 doses of high dose methotrexate, but I think our cumulative feeling was that at least 2 doses should go in. And of course, with dose-adjusted EPOCH-R, it's not easy to give high-dose methotrexate. So intrathecal methotrexate, again, for about 4 doses was what we had thought we would continue doing. And for limited stage large cell lymphoma, just using R-CHOP times 4 rather than combined modality therapy. And for those who tolerate the first dose of rituximab IV, we're switching for subcutaneous administration because that reduces the time they actually spend in the clinic. So are we changing therapies for patients who have already started treatment? So far, no. We're still continuing with whatever they plan they were on. And as far as changing therapy for less frequent visits, So telemedicine is replacing a lot of the routine visits. For example, the visits which are not coincident with treatment, we're doing as video chats. And we are trying to use oral regimens in situations where, at least in the relapsed refractory setting, where we don't have any data for one thing being better than the other. What about patients with relapsed or refractory disease? Again, most of the experts polled, the 6 of us, continue to offer second-line therapy with high-dose therapy and transplant for relapsed or refractory DLBCL. Instead of doing inpatient regimens like our DHAP or our ICE, we've sort of switched to the Canadian outpatient regimens, such as the gemcitabine-based regimen. And again, right now, a lot of the clinical trials are on hold, and we're not allowed to open any new trials. And the ongoing ones are also being used very selectively because all the support staff are actually working offsite from home. So the coordinating support is very has been cut back. So if it's for third line setting in the US, we do have polatuzumab approved. So lenalidomide based or pola based therapy with bendamustine are being used if we cannot take a patient to transplant right away because of staffing issues. And we've seen that the admission for transplant may be delayed in instances if another cycle of outpatient therapy can be administered. Blood shortages are anticipated to occur in the coming weeks, which also will then limit the availability of transplant. And whereas ICU bed availability at most centers is an issue currently, or expected to be in many centers, we haven't hit that in the Bay Area as yet. Some CAR T programs are currently delaying patients and prolonging salvage therapy when possible. As far as supportive care, we're using growth factor routinely in the current environment, even in younger patients. So normally for large cell lymphoma, if you're younger than 60, ASCO guidelines don't really recommend the use of growth factors, but here we're doing it routinely now to prevent a neutropenic fever, and which will land up then a hospital admission. And there are some theoretical concerns that filgrastim might exacerbate the respiratory effects of COVID-19, but as of yet, there is no contraindication to growth factor supports in patients who are anticipated to become neutropenic. So moving on to indolent lymphoma, whether we're changing our indications for therapy, the answer is no. The threshold, in fact, for initiating therapy should be very high, and watchful waiting should be the preferred strategy wherever possible. And treatment is recommended in symptomatic patients. The indication is borderline. That means even if the patient meets the JELF criteria, which is what we commonly use to decide if someone needs treatment or not, but is asymptomatic, therapy should be deferred, and most of us are just monitoring with repeat imaging in a few months. And if patients are asymptomatic, a treatment with rituximab monotherapy is not recommended. When treatment is indicated, we're preferring to use Rituxan monotherapy rather than Rituxan plus chemotherapy. If it's a single site of disease, limited radiotherapy is often an effective option. And many experts commented on concerns about the immunosuppressive properties of bendamustine in the indolent lymphoma setting, and are recommending RCPP or R-CHOP with growth factor support as alternatives, and again, without rituximab maintenance. And as in aggressive lymphomas, those who tolerate the first dose of Rituxan IV, we can switch to subcutaneous administration. And some people are switching to less immunosuppressive therapy. And the use of maintenance rituximab is variable amongst the six of us. Some of us have discontinued it completely, especially after bendamustine, or in older patients, and in young patients who have low immunoglobulin levels. What about changing therapy to minimize visits? So some of us are switching to oral options such as ibrutinib in marginal zone or mantle cell lymphoma rather than continuing intravenous therapy. Again, with the effort to reduce risk of infection and limit the number of visits. Some patients may be eligible to receive up to a 3-month supply of their oral medication. And then this approach with labs obtained locally closer to where they live and telehealth visits allow patients to stay at home for the time being. And then patients who are on watchful waiting may also have their visits delayed with telemedicine alternatives and work with local labs if delayed or if their risk is low. As far as supportive care goes, where the choice of therapies available, options that minimize clinic or chemotherapy outpatient visits are preferred. And again, telehealth is being used more and more for these patients with low-grade lymphoma who we are tending to do much more of the watchful waiting. Again, growth factor support is recommended for patients getting R-CHOP and in selected patients getting bendamustine as well. And then patients with comorbidities, recent infections, low immunoglobulin levels, and those who have received Rituxan and have gotten neutropenic may benefit from immunoglobulin supplementation if available. Now, I want to also just say recently we've instituted a policy that we are, before anyone starts chemotherapy, everybody's going to get a nasal swab for testing for COVID before they can come into the infusion center. They're going to implement this starting next week, and the rest of this week is all the staff, any healthcare provider. It's mandatory testing, a nasal swab as well as serology is being done for all of us, and then the patients we're going to start doing their nasal swabs before they start chemotherapy. Now, this doesn't apply to patients who are already on treatment. This is anybody new starting chemotherapy. It's a little bit of right now data collection because it's a 1-point thing. If they become symptomatic, we could consider doing it again. Now, my topic was non-Hodgkin's lymphoma. Manju asked me to briefly comment on Hodgkin's. And there was much more consensus regarding treatment on Hodgkin's, likely because of the curative nature. The main concern was bleomycin lung toxicity, which is problematic during a pandemic which affects the lungs. And strategies to reduce the risk should be prioritized in all stages of the disease. So for early stage favorable, 2 of ABVD and limited radiotherapy was what most of us preferred. Now, while radiotherapy does require more hospital visits, the ILROG has issued guidelines on how the radiotherapy is modified, and they actually are just doing it over 4 days instead of over 2 weeks. Many centers have moved to omitting bleomycin in early stage patients after a negative interim PET, extending the RATHL data to early stage favorable patients. Now, in some sites, PET-CT is problematic because if it's not available at the small peripheral centers, then to be able to do a PET-adapted approach and drop therapy at the community level gets difficult. For early stage unfavorable, again, we've switched to just basically treating those patients per RATHL with 4 to 6 cycles of ABVD and dropping bleomycin after a negative interim PET. Now, normally with ABVD, we don't use growth factors, but now in this era, we're actually using it judiciously. We're giving it on day 5, 6, and 7, so that it's not too close to bleomycin, mainly so that they don't get, even if they get neutropenic, they don't, to try to avoid a febrile neutropenic episode. So that similarly for the advanced stage disease, for people who meet criteria, at least in the US, the brentuximab ABVD is AVD is a possibility, but you definitely need growth factor support because it's much more myelosuppressive and there's greater cost. For the elderly, we're continuing to use dose-reduced or altered regimens with growth factor use. There's a long laundry list in the NCCN guidelines, and mainly avoiding bleomycin completely. We're not really changing therapy for patients who've already started treatment. As I said before, we're greater consideration of selected use of growth factors and prophylactic antibiotics. And as far as refractory disease, because Hodgkin's still is a curable disease, the gemcitabine regimens are being used as salvage, and some centers are using like brentuximab alone with the lead-in and reserving chemotherapy just for patients who do not achieve a PET negative state after brentuximab. The potential pulmonary toxicity for checkpoint inhibitors are of concern, and all of us are using nivolumab or pembrolizumab very cautiously in this relapse setting. Centers are proceeding with autotransplant, but if the blood supply becomes a problem, then that might become challenging. And of course, allogeneic is not used in Hodgkin's, and we would not be considering it in this current situation. As far as supportive care, I think I've already gone through this before, and that is my last slide. Thank you.
Thank you, Dr. Advani. Manju there? Okay, so we'll move to the next speaker, which is again, Nitin Jain. Dr. Nitin Jain, again, needs no introduction to us. All of us know him, and he's going to talk to us on chronic lymphocytic leukemia. Nitin, over to you.
Sure. Okay. I hope you can see my slides. So
yeah, we can.
Okay. Good morning, everyone. I would like to thank Vikram and Manju and HCC for organizing this. So my topic is CLL management during COVID-19. And as was mentioned before, I think one thing to realize is that there is very limited clinical data out there for leukemias and specifically for CLL. So everything is just what we think should be done. But and I had few patients we have managed with the CLL with COVID-19, and maybe I can towards the end talk about that. I just thought I would show the slide, which is the Johns Hopkins website, just to kind of give a perspective of as of today, or as of a few hours ago when I made this slide. There were 2.7 million cases in the world, with close to 200,000 deaths from COVID-19. And I was actually intrigued. In New York Times, they have this chart by the country, and India is obviously listed there. That just shows the trajectory of the cases. And as you can see, some of the countries, such as Italy, Germany, the slope is going down. US is stabilizing to going down. But certainly in India, though the number of cases are less, the slope is still, as you can see, is going up. And this was another from the New York Times, just kind of looking at the number of cases and the number of deaths. Again, this is much less than what is in US and New York, but at least just giving a perspective that the number of cases are on the rise in India. So now coming to my actual talk. So as you know, I think as I mentioned before, in general, there are no CLL specific data available at this time for the COVID-19. We could assume that given the immunosuppression for patients with CLL, they will be at high risk of severe complications. And as was mentioned before, certainly social distancing is appropriate and very, very important. And certainly in India with the national lockdown, I think that's what's happening for the last few weeks now. Now, I only have 3 or 4 more slides, but I thought I will go through kind of each patient kind of aspect in a way. So for patients who are not on active therapy, so these will be patients who are rise stage 0 patients who are on clinical observation, or patients who have had prior therapy, maybe FCR, but currently they're in remission and they're not on active therapy. Many of them, we see these patients in the clinic every 3 to 6 months for routine visits and blood counts. But here, you know, I think certainly routine clinic visits can be avoided, and you know, certainly telemedicine, calling the patient and making sure they're okay, and then deferring their visit 3 months down the line, I think it's quite appropriate. These patients should not be coming to a medical center or hospitals just for these routine follow-up visits. I think for patients who are about to start therapy, so this could be a first-line initiation of therapy or a subsequent line initiation of therapy. I think most times for patients with CLL, there is nothing that you need to start treatment that very day. There are certainly exceptions to the rule, but a lot of time therapy could be deferred for some weeks, sometimes certainly a few months. So in our practice, we are trying to defer therapy for patients with CLL, at least for 3 months, or at least 2 or 3 months, hoping that by that time, the COVID-19 will be less of an issue. And again, most patients, I think with CLL, you're able to do that unless there is an immediate need to initiate therapy. Now, the field of CLL has changed quite a bit, as has field of AML, myeloma, and others. And so these days we are using, at least in the United States, less and less of FCR or chemoimmunotherapy, and we're relying more on target therapies such as ibrutinib, venetoclax. Now acalabrutinib is also approved. So I think the general thinking here would be that you should consider using non-myelosuppressive therapy. So certainly staying away from FCR. In that matter, you can argue again to stay away from bendamustine rituximab. And then again, because of the effectiveness of target therapies in CLL, really be preferring use of target therapies as opposed to chemoimmunotherapy. I think patients who are receiving active therapy, we have several patients obviously receiving target therapies on clinical trials. For these patients, we are continuing the same therapy. There is no reason to stop ibrutinib or venetoclax for a patient who have been receiving them. But I think for these patients, certainly many of these patients do come to the clinic for visits, and those visits could be curtailed for these patients. And again, if they are from out of state, for us in Houston, we try for them to get local labs, which can be faxed to us rather than for them to make visits to MD Anderson for follow-up for their toxicity assessments. I think an important aspect is patients who turn out to be COVID-19 positive. How do you manage these patients? So as Naval had mentioned in his talk, thankfully at Houston, at MD Anderson, we have not had such a surge so far. So we have been lucky that way. Now, we haven't had a patient with AML, I believe, who had a COVID-19, but we had several patients with CLL who are actually, few are admitted to the hospital right now, and some have been discharged. So I think the question arose that actually the patients were on ibrutinib, and what to do with their ibrutinib if they develop COVID-19 disease. Now, there are certainly no standard argument here. There are pros and cons of holding therapy such as ibrutinib for these patients versus some risk involved in continuing therapy where risk with ibrutinib, a concern that you may not be able to mount an immune response to COVID-19 if a patient is on ibrutinib, and also the potential risk of atrial fibrillation and ventricular arrhythmias with ibrutinib. So I think the patients who are COVID-19 positive, for the patients we have treated or I have personally involved in the care, we have decided to hold the ibrutinib during the time they were being treated for their COVID-19 disease. Certainly the management of COVID-19 is outside the purview of this talk, but certainly follow the institutional guidelines. We have used IVIG not to treat COVID-19, but to prevent secondary infection in a patient with CLL, certainly if their IgG is low. I thought I will just highlight there's a recent report in Lancet Hematology. It's about a patient with CLL who had multiple prior therapies, and then he developed COVID-19 disease. Patient did well. His CT scan is shown actually, which is very informative because that's one of the classic pictures of CT scan you see. And then patient did well with the treatment for their COVID-19. This was a patient in China. So with this, I would like to conclude and we'll take questions at the end. Thank you.
Thank you, Nitin. I think I just want to remind the audience that to please use the chat facility to put in questions to the panelists and the faculty, and we will come to them at the end of all the talks. And I request Elias to come back again on and give a brief overview of CML in the COVID era. Elias, over to you.
Thank you, Vikram. Again, this is my second part. Few slides about what we're doing in Houston before I go over the COVID-19 crisis. And most of what Nitin has said about the crisis of the disease apply to CML. For example, the visit. We're not seeing this patient anymore at the hospital. We're applying telemedicine, we're testing their PCR at home, they ship it to us. So essentially these patients are not coming to Houston. So in the front line, we have 4 options available, but I would show you at MD Anderson, we're using imatinib and dasatinib. Here, our choice of therapy has been, and it's in—
Elias, sorry to interrupt. Do you have a set of slides or it's not on the screen if it's there?
I'm sorry. So
you have to share your screen so that it—
Yeah, got it. Okay. I'm very sorry.
That's okay.
I thought I did. No. Just let me try one more time, please.
Okay, it's come on.
Okay, good.
You need to go to screen show. Okay, perfect. That's fine.
Okay, so in Houston right now, our practice has been for frontline therapy, dasatinib 50 milligram per day or imatinib 400. And for patients who failed dasatinib, we moved to ponatinib, but we do not use 45 milligram per day. I will come back to that because at 45, we have risk of thrombotic event, and that is very concerning in a time of COVID. Nilotinib is a second line, especially if you have a mutation specific that can nilotinib be effective. And then bosutinib as a third line if ponatinib cannot be given. If we're starting with imatinib therapy, then dasatinib second choice. If dasatinib is not working, then ponatinib. As you can see here, we don't use nilotinib because of the risk of vascular events. And that seems to be a problem with the COVID time where we do see a lot of thrombotic events. In a frontline therapy, 16 randomized trials were done. None of them has shown a survival benefit over imatinib therapy. Therefore, imatinib is a good start. And as you know, in India, the largest series assessing generic of imatinib was done in India with more than 1,300 patients, and therefore we're comfortable using imatinib in the frontline. I want to show this slide for a simple reason. This is the 10 years update of the NSND comparing nilotinib to imatinib, mainly 600 milligram per day. Survival, no difference. But if you look at the cumulative event of vascular events, it goes up to 30% with nilotinib. So we do not use nilotinib for this reason. Furthermore, if we're worried about a COVID infection and thrombotic event, which seem to be the cause of death in these patients, then nilotinib and ponatinib should be avoided in these patients. So regardless of the COVID time in Houston, we're using imatinib mainly for low-risk so-called disease, or even for high so-called score disease if the price of second-gen TKI is expensive. No, if the price is not a problem and somebody with high risk and younger people, our choice of therapy is dasatinib 50 milligram per day. And it's important during the COVID time because with the dasatinib 50, we're not seeing any more pleural effusion. We know that dasatinib can cause pulmonary problem, and therefore this can worsen COVID infection hypothetically, and therefore should be avoided. So here the data with the 50 milligram of dasatinib that we have at MD Anderson. We published the longer follow-up of this trial, but clearly MR 4.5 at 12 months is 50%, which is better than dasatinib 100 milligram per day. And these responses are improving with time. So we strongly believe, based on the data we have, that 50 milligram per day should be given to these patients. It's safer, and if you have a COVID crisis, that can cause less problems. So here the comparison: in red, dasatinib 100 milligram per day, in blue 50 milligram per day, and imatinib the green at different time points. But we define optimal responses were seen at a higher rate with dasatinib 50 milligram per day, and the reason is because of less complications and more drug exposures. Now we know that all these TKIs, they can have their specific side effect, and that should be taken into account in a COVID time. For example, I mentioned nilotinib, the heart issues, ponatinib thrombotic events, dasatinib, bosutinib diarrhea. We know that one of the symptoms of COVID infection, not only respiratory, but we've seen patients having diarrhea and taste disturbance, and therefore one should be very careful when giving bosutinib for these patients. Dasatinib, of course, can cause the pleural effusion. Therefore, the risk factor for during COVID time in CML, the cardiac injury due to mainly nilotinib and ponatinib and less so to dasatinib, pulmonary injury to dasatinib, and again, the thrombotic events seen with ponatinib and nilotinib therapy. So the side effect profile should be really considered when you have somebody with COVID-19. The complication can be measured, the pulmonary failure, the cardiovascular problems, including cardiomyopathy seen in a third of these patients, cardiac arrest, diarrhea when you give bosutinib by thrombotic event. If we know the symptoms of COVID, then we can adjust our therapy and prescribe the drug mainly at initiation that is the most appropriate. We know that, for example, this event may be worsened with TKI that can cause similar toxicities, mainly lung issues with dasatinib, thrombotic events with nilotinib and ponatinib, and diarrhea and bosutinib. So if you have somebody to start therapy today, I will select my TKI based on these factors, and therefore I will try to avoid them to minimize complications with COVID time. Now, again, we have not had a single patient today with CML. We're all preparing for this surge to happen. CML today, asymptomatic, we're not worried about them, mostly telemedicine. But patients who are symptomatic, then we swab them PCR, and we're eagerly awaiting the serology to happen, so to check if somebody's infected or not. If an infective infection is positive, mainly with the PCR, there's no rush to keep TKI. I think we should hold TKI till full recovery. Ideally, we would like to have IG serology. Today, Nitin shared with us one of his patients his spouse had IgG positivity in Michigan. Now, for those who advanced stage disease, I think the story will be like we do with acute leukemias, where we have to treat, we cannot hold. But then, of course, you have to measure the pros and cons. And I will favor less intensive approach. For example, Blena and ponatinib for lymphoblast crisis, TKI, venetoclax for patient in a blast phase disease. For the routine patient who are being treated, we're checking PCR every 3 to 6 months, and that can be done locally. They ship us the kit, we can run a PCR, and of course we call them and we discuss with them the findings. Attempting TFR in Houston right now is being delayed because these patients will require PCR to be done very closely. But somebody who's already in treatment for remission, they should continue. There's nothing to be managed differently. So to conclude, at the start of therapy, again, consider the drugs that will not interfere with eventually COVID infection. I will consider imatinib or dasatinib 50 milligram per day. I will avoid bosutinib because of diarrhea and nilotinib because of thrombotic events and myocarditis and heart issues. Patients who are receiving therapy, I will continue to monitor them via telemedicine. They don't come to the hospital, to MD Anderson. And of course, I will delay a TFR initiation. To conclude, this is the same slide I showed before. Again, weigh the treatment if you have a potential cure versus minimizing therapy. Minimize patient exposure. Use whenever you can treatment that is effective, and take advantage of technology, telemedicine. And again, every patient should be treated individually and decide on his risk factors and keep standard hygiene. And I think even when the COVID crisis is over, the social distancing and hygiene should be really implemented. I think something we will carry it with us even after the crisis. Thank you very much. And I think we'll have the discussion at the end.
Thank you. Sorry, Manju, go ahead.
Thank you, Dr. Elias. That was really nice. And it appears that probably CML seems to be one of the easier situation to handle in this particular era. With that, we will move on to the last topic, that's multiple myeloma. And Dr. Sundar Jagannath will speak on that. And the main difference between rest of the speakers and him, that he is in the heart of the situation. So New York is one of the worst hit areas. So probably he'll be able to give us better perspective. But at least in Mumbai, we are going to face quite soon, it looks like. So over to Dr. Sundar Jagannath.
Thank you, Vikram. Thank you, Manju, for the kind introduction and also inviting me. Let me make it full screen. I hope you can hear me clearly.
Clearly.
Well, I've just broken down my topic into 3 during pandemic, which, as you alluded to, Ranjani Advani said they didn't see any surge at all. So it's clear that people who are in pandemic have a little different approach to management. And also, ours is not just a cancer hospital, it is a medical school, and with multiple hospitals in the 3 boroughs in Manhattan, Queens, and Brooklyn. So we really had a surge, and we did see that. So I'll talk about pandemic, what happened, then what we are planning for, because this is now we are coming to this recovery from pandemic phase, and then we will go to long-term management. So globally, you heard Nitin show the slides. You had 2.7 million with 188,000. But if you look at United States, that's pretty high compared to many other countries. So we are still 1/3 of the world cases are here, even though the mortality is, a little lower. And the New York State, if you look at that, we have 1/4 of the US, or a little more than 1/4 of the US experience. And you got to remember, this is actually in a dense area surrounding New York City per se, where 10 million people live. So this is where it has hit us. And you can see that has been a significant mortality, but the mortality is comparatively lower when you look at the other statistics. So what does this mean? So if I put it in what happened in Mount Sinai Health System, we had something like 50 patients on March 17. 10 days later, by March 27, we had 1,000 patients, you know. And another 10 days later, by April 4th, we are looking at 2,000 patients in the hospital. You know, all the ICUs, half of them required ventilatory support and or ICU support. No surgeries, elective or otherwise. All the anesthetists were busy intubating patient. Oncologists were busy taking care of COVID patient because there were 20 COVID medical services with anywhere between 10 to 15 patients in each. So my colleagues were all deployed taking care of COVID patients. So when something like that happens drastically, then, as soon as the surge happened, we were alerted because we were looking at that time what was happening in Italy and were preparing ourselves in how to. So we really drastically reduced our clinic, cancer institution infusion volume. And so we implemented, dramatic mitigation, drastic mitigation strategies in our institution. So if you are looking at something like this, hopefully, by curbing people's travel, etc., stopping, cars on the freeway and the trains and planes, and in India, they have really tried to flatten the curve very much, and I really appreciate that. It did not happen in New York area, as you can see from the surge. And what we see is there were, we really tried to keep the patients at home, immediately reduce the chemotherapy treatment, only patients who need it. Those who really need it, who are newly diagnosed, started on treatment, or who are having progressive disease, or those who are on clinical trial at this time and are on treatment and responding because they are on a clinical trial, they were all cared for in a secure manner. So we did not change management that way. But the patients, many of them in myeloma, we did change them into oral agent and reduce the infusion volume, as I showed you in the previous slide. So we did video visits or telemedicine to reduce the clinic volume. And why is this was very important for us to drastically reduce the volume of cancer patient coming to the institution? Because first, it was the safety of the patient. Because this is pandemic happening in the city. People have to travel. If they get out, they all get sick. So, and especially public transportation. New York is only city in United States with a very good public transportation where, million plus people use that every day. Manhattan is, in the nighttime, is 2 million people. During daytime, it is 5 million people. So you could see 3 million people pour into the city every day to work, commuting there. So this is why we really had this. So we had to show that these measures were beneficial for patients, providers, and institution. Why patients and caregivers were saved unnecessary visit, exposure, travel to the center. It saved the valuable time of the clinical staff, reduced their exposure by allowing telemedicine. But it allowed the institution to cope with the surge of patient volume by redeployment of the staff and the resources such as pharmacy, nurses, physician to take care of the patients who are at our doorstep. And the cancer center infusion space, part of it, which was, individual cubicle, they build beautifully these days, they were actually made into a COVID negative cancer patient hospital. So the inpatients were all swallowed by the COVID patient. So the patients who were there, this was a COVID negative area, and we could provide care for the cancer patient in the outpatient setting. And also by reducing the patient, we were at the time when PPE was a real problem, So, this saved us personal protective equipment by reducing drastically the patient. And all surgeries, all elective surgeries were absolutely abandoned. Transplantation was all. So these were drastic measures. And this happened in all the major institutions in New York City. And that, is when you're in the middle of pandemic. None of you have experienced it, and I don't want anybody to experience this, but this is the way you prepare this and how you manage is completely different. So fortunately, there are many oral agents in myeloma which allowed continuation of the therapy even when they were at home. So nobody was stopped from treatment. And I will tell you, and utilization of supportive care medicine like bisphosphonates, denosumab, IVIG, they were all drastically reduced at this time. We felt like the IVIG is not going to protect you from COVID. So by the time you come and get your IVIG, you will go home with the COVID. So, this is a completely different way of looking at and doing. And also we made communication with the patient who develops fever. They would call, our on-call myeloma physician. Then we really knew, very attuned to what the ER admission requirements are. You have to have pneumonia, and your pulse ox has to drop below 92% if you're going to be admitted. So I asked the patients to go ahead and buy a pulse oximeter and also thermometer, and just be in touch with us to tell us, as long as their pulse ox is over 90, we let them stay at home and not come into the hospital. Why? Because this is really a disease of isolation. You will come and admit your father, and that's it. You can never visit him, and then he'll be in the hospital. People will be coming periodically to take care of them, but they have to share, preserve the protective equipments, etc. So they can't be coming at beck and call of the patient. And if the patient is on oxygen, high flow, etc., they are not in communication with the family. So when the physician came to round on them, they will call the family member. They will allow the video chatting with the patient, let them see how the patient is, and give them an update. So this is, and if the patient dies alone in the hospital. And then, subsequently, because there was so much flooding on the morgue, etc., even the funeral doesn't happen the same day. So this is really something you have to consider seriously, how you want to manage the patient. So for us, keeping the patients home. So I can give you statistics. The statistics are available, but just in a broad sense, I couldn't put it there on the slides, etc., because it will be published, publishable thing. So we had 50 patients with myeloma with COVID. Half of them just stayed home, and we managed them at home. They became completely successful. There were patients whose husband developed COVID. The mother-in-law was admitted. The patient, then when the mother-in-law was being discharged, the patient asked me, this was only today, the conversation, or yesterday. I told her, she was worried, what am I going to do? I said, your husband got COVID, you have COVID. You don't show the symptom. Oh, but I have myeloma. I said, nothing doing. You have COVID. Go get tested. Sure, she went and got tested. Of course, she was COVID positive. But the difference is the myeloma patient shed for a long time. 5 weeks, 6 weeks later, they are still shedding the virus. So I told her, now you cannot go to the grocery. Your husband is not shedding. Your sons are not shedding. But you can't go to the grocery. Only they have to go for grocery. So testing them becomes important. In this regard, Mount Sinai had rapidly developed it, got the FDA approval to do the testing in the institution, and we could have turnaround time 2 hours in emergency cases. We can have small volume of people. We have 2-hour turnaround, but in the majority of the patient, it takes about 6 to 8 hours turnaround of that. So ability to test the patient becomes very, very important. And also in the early stages, our idea had said, go ahead and give hydroxychloroquine plus minus zithromycin, but there is a QTC prolongation. So if you want to give, once the patient called that they have fever, you have to review the chart, also look at their EKG and look at the QTC, and then decide you can give hydroxychloroquine, but not zithromax if the QTC is already on the larger side. So you have to page that. But most important is when you allowed the patient to stay with the pulse ox and things like that, and you were reaching out at least once or twice a day, the patient felt very comfortable and they got over the viral infection. And this is, after all, a viral infection, and many of the people do it. So let's go back, 50 patients, only 25 got admitted. Of the 25 who got admitted, only 5 required oxygen, and the mortality was only 5 patients we lost with myeloma. So the statistics of horrendous death and with cancer on treatment, etc., we did not see. All the other statistics will come in the other disease too. But, this is just our experience. We are still in the pandemic phase. From 2,000 patients, we have come down to 1,500, and we are saying, oh, it is coming down. But still, 1,500 patients is not a joke. in your institution. We still have the COVID rotation. So communicating with the patient and keeping them comfortable is very important. And when they have developed COVID, then you have to come and be retested, and you want to get them, negative status. Myeloma patient, it stays there. They shed for quite a while, at least 4 or 5 weeks. They still are positive. Then provide video visits, telephone visit, etc. So what did we do? Elective procedures such as stem cell harvest, transplant, etc. They were all completely postponed. Anybody coming for restaging bone marrow because they are in remission 1 year, you want to come from MRD negative. So those are all now luxury. You don't bring them in for any of this annual restaging, biopsies, imaging studies. They've all been postponed. All clinical trial enrollment has been put on hold in the whole New York area and in Boston too. So clinical trial enrollment on hold, but the patients who are on clinical trial, we allowed them to continue, and I will tell you what the NIH put out, which we are following. The patients already on trials, we continue the IV treatment, bispecific antibodies, subQ daratumumab, antibody drug conjugate. They are all still going. The patients are getting it. Strategies to limit risk and patient visit for enrolled patient are implemented. Supportive care medication, I already told you. Then in myeloma, proteasome inhibitor, Kyprolis and Velcade, you can give Ninlaro or Ixazomib. So patients who are in partial remission or better, who are responding to therapy, switch to Ninlaro. But somebody in the progressive disease, and you thought Kyprolis was important because of whatever high risk, if you believe in it, you can go ahead and give it. I don't think that the choice of therapy, we cannot say mattered very much, because among the patients who had COVID, I talked about, we had a smoldering myeloma patient, we had patients in remission, first remission, who had COVID development. So it is not a matter of the disease phase alone. Actually, many of the relapsed refractory patients did not get sick. Then, of course, the drug companies make the IMID patient pregnancy testing at home. The daratumumab and elotuzumab. Elotuzumab causes quite a bit of lymphopenia, daratumumab. But the patient who really started it, plasma cell leukemia, I just started a patient. That patient is still coming and getting the daratumumab weekly. So despite that, we are continuing those kind of management which are required. And whereas the patient who are already in VGPR or CR, there we have script 2 months worth of monthly daratumumab. We said no. 2 monthly elotuzumab. We said no. So we used a judgment to say who should not come and who should come. So, this will vary. That's why I don't want to say how I would manage from how, in Stanford, they'll manage the patient in myeloma would be different, simply because they don't have the surge. One good news is FDA set up a separate portal for clinical trials. So there is a large number of clinical trials happening. BTK inhibitors is one of them, anti-GM-CSF antibody. There are multiple anti-viral drug. One of them is actually a myeloma drug called selinexor, which blocks the exportin-1, protein transmission from the nucleus to the cytoplasm. And apparently, even though it is an RNA virus, it is also requires a little bit of the transportation between nucleus to cytoplasm, and they are showing data. Anyway, they have a randomized double-blind study approved by FDA, and it's an international study. But the company has also made compassionate use drug available. And I know selinexor study was also done in India. And study visits delayed, missed, these are all now accepted. Phone and video conferencing, patient can get their local lab and you do your phone and video conferencing. That is all acceptable now for the clinical trials. So these are all put in, implemented thanks to NIH putting out this, and the pharma industry following that, and FDA. So there is a tremendous collaboration between the academia, FDA, NIH, and others. If you want to know how the myeloma is, smoldering myeloma, by definition, they don't need treatment. I don't see why you have to treat. We heard that in CLL. So don't treat them, during a crisis. Why do you have to treat them? Whether high risk, low risk, those are all esoteric. Somebody wants to do somewhere, let them do it in Timbuktu, but not when you're having COVID. Newly diagnosed patient, you have to screen them for COVID-2. Patient testing positive, if you can, hold treatment until they have convalescent. they have recovered. Treat hypercalcemia, but try to use less juice. I'm going to be running out of battery in my computer, so I better hurry up. Then you have, those who are COVID-2 positive, somebody who needs treatment, then they have to be kept in a separate area because we have to have a special area for them to be treated. Renal impairment, complication could be managed. And those who are negative, it is preferred that you go for oral agents at this particular time. Maintenance in myeloma, it's all oral. You can continue with your maintenance, but if it is an IV, somebody is doing a data maintenance, I don't think you should do it at this particular time. So most of it, as I wanted to say, is common sense, which you heard from everybody, repeated from MD Anderson. Even though they have not seen the surge, they have pretty much implemented what we want to do. Recovery phase, that is the next phase, which will be happening. Then patients need to be tested because in the community at a large, there is high amount. So right now, New York State government put out the notice, they tested 3,000 people randomly. 25% in the community had seroconversion. So you could see also, as I said, myeloma patient keep to shed the virus for quite a long time. So right now in the immediate post-pandemic, at least in New York area, we need to test them. You may not necessarily need to do it in a different place like Stanford if it's not very high, but in New York area, you really have to do where there has been a surge and it is going down. Before each cycle, before enrolling on clinical trial, before high dose therapy and transplantation, once you start moving forward. And in positive patient, you should take a pause, hold treatment till they get better. And if this asymptomatic viral shedding, like I said, some of my patients are still shedding. If the disease is going to move, and if serological testing, and if their antibody is positive, then it's your guess as well as mine. There is no evidence, but this is the time you have to make a decision whether you're going to let the disease take over or you're going to do something about it. The chances are we may want to treat those patients with little bit gently, if at all possible, oral agents or even IV, but not drastically make them neutropenic or something like that. So that's something we need to keep in mind. And patients who have recovered, please check for antibody seroconversion so you know. Myeloma patient, to my absolute surprise, they were converting the patients I have tested, every one of them have actually shown maybe this virus is much more potent than our pneumococcal pneumonia vaccination or flu vaccine, because it has been published, more than half of them never turned positive. But this COVID must be pretty effective in stimulating the immune system in a way, because we are seeing that there is seroconversion there, and we want to keep an area where positive patient will be treated elsewhere in a separate place. Negative patient will be treated, because it is also important for the nurses who will be taking care of positive patient, that they have to be a protective environment. What will be long term? I think during the flu season, etc., now coronavirus testing will be automatic in the BioFire. When we check for many viruses, this will be automatic. Telemedicine is here to stay. We heard that from our colleagues. Social distancing in waiting areas, wearing masks. This, if you travel to Japan and all, you would see people wearing masks in the public transportation quite often if they have cold or whatever. Very uncommon. In New York, nobody wears anything in the subway, but now I think those kind of behaviors will change. Hand hygiene, and we hope in the very future, maybe vaccine or maybe one of these antiviral therapy will turn out to be positive. And I will stop here.
Thank you, Dr. Jagannath. That was really wonderful. And the best part about the talk, that the outcomes are not too bad as we were expecting, or whatever the limited data is available from China and other setup where the outcomes in cancer patients with a very limited data set of 18 patients, they showed that the outcomes are poorer. I think this looks much better. So I think it's very important how we approach these patients. Since your battery is running low, maybe I'll take up questions directed towards you first, and then we'll move to the other speakers. So the first question, I'm not sure whether anyone has an answer for that, is that how long do you think it will take the pandemic to settle in New York?
I think we are turning the corner, but from 2,000 patient to 1,500 patient is not a great thing. But they are telling us the emergency room is coming down, the discharges are increasing. But one segment is not clearing, and that is the patients who are on ventilator. They are not getting up that easily. And so that means for us, the ICU is still an issue. So starting, when do we want to start CAR T cell therapy, etc.? You need an ICU. So now they are creating within the Mount Sinai system, the SICU COVID-free area is being created. And so that the surgeries, urgent surgeries and others which have been put on hold, they can move on. But I really think for us, it'll be another month. So, you know, politically for job and economy, they may start a little bit sooner, but really the surge going down for our institution to really feel that we are off and no more COVID rotations for our faculty. All of that would happen. I think it'll take us one more month.
Sure. So the other question, which I'm not sure whether it's only relevant for this era, meaning when we talk about COVID, whether it's probably relevant even otherwise, would you recommend upfront vaccination with the quadrivalent pneumococcal influenza vaccine for all the patients with myeloma?
Well, you know, that even with or without COVID, when you have just diagnosed a myeloma patient and they need treatment and you're going to start treatment.
I think we've lost Dr. Sundar Jagannath's computer,
Okay.
Manju.
So till such time he's back, maybe I'll just go on to the other questions. So one question which, there was some specific question in terms of how we are going to manage an individual case. Before we go on to those individual case settings, maybe we can just take some general questions. So one question is that if a patient is positive before starting treatment for ALL and AML, or if he or she becomes positive in initial week, would you continue to treat him, or would you like to delay, and if delay, how long? So maybe Nitin, anybody can.
Happy to answer. We have not seen a single patient yet at MD Anderson with AML, ALL, COVID infected. I have a patient of mine that Dr. Jain is following. We're suspecting his ALL having COVID infection. PCR has been negative 3 times, and we on a CT scan had some features. That being said, if I have somebody with COVID positivity, I will not treat this patient. I will wait till he recovers. I may give growth factors, whole treatment, support him with chloroquine, azithromycin, you name it. And then I will not resume therapy till this patient become negative PCR, twice ideally IgG positivity, and completely asymptomatic before I resume therapy on this patient. And if he's young and if he recovers fully, I will not, I will still deliver optimal care to this patient.
So on the same lines, maybe when we are talking about them becoming PCR negative and developing antibodies, can we just take up this question that do you think that our patients, meaning I'm talking about from the hematological malignancies point of view, do they continue to shed much longer? As Dr. Sundar Jagannath said, that myelomas do that, what in their data set. But is there an evidence or any from any other malignancy in hematological malignancies area, whether these patients continue to shed for a longer period of time?
You know, at MD Anderson, we had a major hit in lymphoma more than leukemias. Fortunately, in leukemias, but I don't know. In leukemia, I don't know.
Okay. Anyone else have any other comment and thoughts?
I don't think we have not done longitudinal testing on these people to know how long they're shedding. So yeah, we don't have that data, and I haven't seen any published or discussed data to that nature, except for what Dr. Jagannath said, which sounded like it is longer, 5 to 6 weeks in myeloma.
Yeah, all the patients, when they're coming back in New York area, they are getting retested now because, as I said, in a pandemic environment, you have to behave differently. when the serology is 25% in the community. So, that's why I don't want to say how patients should be managed necessarily, how you will manage in University of Albuquerque, New Mexico will be completely different compared to what we went through. So, but New York is unique in the sense we really got the worst brunt. At least from the published data, we surpassed Wuhan, if you want to believe the data, right? We have more death and we have more people than Wuhan had. So I think these data is coming because almost all the institutions here by nature have to test the patient. So within a month or so, I'm pretty sure everybody is ready to write their letters and early publication and being restless. All of that you will get. So I think you will get that information. But what I was impressed is among the 50 patients we had treated, we thought elderly patients and relapsed refractory would be running into trouble, but actually the age, it was not necessarily the elderly patients alone, even though the median age is 69. We had younger patients also, and that is simply because, just like I said about the woman, her husband goes out to work and he brings in the COVID. In the other patient's case, somebody else goes out and the spouse gets it at home. So once they come home, the entire family gets it. And even though the entire family gets, only one or two of them are sick and the other people do not know. That's why I was very confident in telling this patient when she said, my mother-in-law is coming, what should I do? My husband has recovered and I'm wearing all the mask and I'm doing protection. I said, you are positive. Your husband has it, you got it. And when she tested herself, she was positive. And repeatedly it's happening in all the families. If one in their household has come in, pretty much everybody has it. And that's true even among the physicians, because our ICU, my colleague, intensivist, she got sick, so she stayed home. Her two children got it, but they got a cold. The husband had no symptom. But if you test them, I'm pretty sure all of them were positive. And the sad part is for us, a nurse, she went home, she was positive, transplant coordinator. Her parents got it. Both of them died on the ventilator. So it's very difficult to really fathom it. So it is not like maybe the leukemia. When you spoke, you said that maybe the AML patients are known to protect themselves and maybe they keep themselves secluded. Maybe that's why the incidence is lower or whatever. But it is, you really have to pay attention at this time of social distancing.
Maybe can I ask a question to Dr. Jagannath? I think maybe learn from his experience. So we had, at Anderson, a couple of times where we had patients who were nasal swab was negative for COVID-19. And then we did a BAL for these patients and the BAL turned out to be positive. At least we had one patient like that. And today I heard about a patient who was on serology was diagnosed, to have at least a prior exposure of COVID-19. So just kind of curious with your experience in New York, have you had patients where the diagnosis was based on BAL only, then nasal swab was negative, or based on serology?
I don't think I would go as far as the BAL because these patients, when they were coming in, 1,000 into the emergency room, I don't think our pulmonary critical people's time and effort is not doing BAL, to be honest with you. But there have been patients where, radiologists are pretty comfortable. The clinical history is the way they presented at the time of your pandemic. So even if the patient had tested, because they told us right up front, you would be 70%, accuracy, and you have to have at least 3 different areas of the viruses picked up, in the PCR technique. 2 only is not that enough, because earlier version was only looking at 2, so 3, and so developing all those things. So people are aware. Those kind of information will also come because these people, they actually needed respiration and they needed to be admitted. So, the patients were cared for, so then the dust has to settle to really get all this data. As you can imagine, there is a queue of line for IRB. First was, trials. trials that needs to be happening in these patients. And then they said there is a queue of retrospective studies requested from so many people. Renal failure by cardiologists, renal failure by the nephrologist, renal failure by oncologists. Everybody wants to write about, so it's kind of one of those scenarios. A lot of information will come, but I honestly cannot give you the answer.
Okay, sure.
So just to add what Dr. Jagannath said, we know that the BAL is going to be much more sensitive as compared to the nasopharyngeal swab, but the risk of aerosolization to get that BAL is high, and we really don't want to expose people in the era when there are so many limited PPEs to make sure that we get BAL rather than getting a nasopharyngeal swab. So that's why even at our center we are seeing now more and more increasing number of cases, but we are limiting to nasopharyngeal swab. So coming back to Dr. Jagannath again, do you advise reducing the dose of steroids in a myeloma patient? And if yes, how much? And which are the patients where you would consider a dose reduction?
Okay, somebody who's on achieved remission, because the protocol says Revlimid plus dexamethasone, we have taken, once the patient's disease is into remission, we have backed off of the steroid, for a couple of months. Just like I said, for a couple of months, we have backed off of this thing. So my feeling is, Manju, you would make the same decision I make as physician at the bedside. You basically, if you can avoid immunosuppression and lymphopenia in this particular patient at this time, you want to reduce it, because taking care of a patient, you don't want these patients. In New York, you don't want patient going to hospital. That was the mantra for us, because even if you went in for a heart attack, you are isolated. There was nobody allowed to come and visit patients. You were set there by yourself. So it is an environment where you really don't want to create unnecessary. So I don't want to say that I know evidence and 100 patient this way, 100%. And I'm talking to you, all of you are very, very senior, accomplished, clinical investigator and hematologist, oncologist. So I would just say, I would try to reduce the steroid in those who really don't need it at this particular time. I would leave it at that.
There are two controversial questions in terms of HCQ prophylaxis for healthcare workers and for patients, and the frequency of testing. I'll keep it for the last, but I'll take few other questions. So one of the question to Dr. Advani, in case of primary mediastinal B-cell lymphoma or double hit lymphoma, is it okay if we continue R-CHOP till the crisis get over? Because those adjusted REPOC may require multiple visits and multiple admissions for blood counts or the management of complications.
So for primary mediastinal lymphoma, I think people are switching to R-CHOP, and then the thing is that you need radiation usually after that, whereas with those adjusted EPOC, you could get away without it. I think for this for double hit, we know that R-CHOP is inferior, but again, it depends on your local situation. I mean, you heard from Dr. Jagannath that because they had hit so hard that the priorities changed completely. And in the Bay Area, we did not have a surge. So we had a lot of the usual options we do. So I think you sort of have to, there's no hard and fast rule. And you have to see what your local situation is like and what supportive care you can give. If your hospital is in a situation where you're already full and your blood bank and your other services are already full, then no, of course you do only outpatient stuff and don't do dose adjusted EPOC. But if you're in an area where the surge is not there and you have full supportive care, then I would think that the more intensive therapy for double hit is slightly better, because there's no, the results with R-CHOP are inferior. So I think you almost have to individualize it. I don't think there's a hard and fast rule.
So absolutely, we need to look at our own situation, where we are,
exactly,
how much resources we have, and what's the tolerance of the patient which you expect. So if anything is not in your favor, probably you will have to switch. Coming to Nitin, two questions since we are talking about steroid dose reduction. So if you have autoimmune hemolytic anemia in chronic lymphocytic leukemia in the present scenario, how would you handle these patients? Only autoimmune hemolytic anemia, no other indication for therapy.
I think, again, it's again, the standard would be steroids and generally a CD20 monoclonal antibody like rituximab. That's what we do. Now, again, I haven't had a situation like this, but I think then maybe rather than using both together, maybe considered the steroids, it may be easier to prescribe it to be taken at home rather than coming to the hospital to get the rituximab infusions. Um, again, I mean, I think if a patient is really, has a very low hemoglobin, you have to treat those patients. Um, I think steroids, oral steroids, may be a way to go if, again, you're in a situation like a pandemic, like in New York, where it's difficult to come to the hospital. But if you're in Houston at present time, we certainly could do mostly what we would do normally in a general situation.
Okay. So probably both Dr. Advani and Nitin, both of you can take up regarding the bendamustine. So if a patient is already on bendamustine rituximab, would you want to discontinue, or you would want to continue in a setting where you've started to see the cases and you otherwise have resources to manage these patients? So whether we would want to discontinue bendamustine or any particular number of cycles where we want to stop?
Okay.
So I think we said in low-grade lymphomas that if the patient has achieved a reasonable, they're not curable, low-grade lymphomas. So if the patient has achieved a very good remission after 4 cycles, we are stopping it. We're not continuing it beyond that. And there's really no role for any maintenance therapy after bendamustine is particularly immunosuppressive. As far as, I mean, it's I think I saw a question in the chat, would you reduce the dose or prolong the treatment? No. I mean, I think if you're giving it, you give it. And we are, as I said, if patients have achieved a remission, doing 4 cycles and not pushing them to the full 6.
So again, in the same direction, Nitin, for you, data regarding ibrutinib. So there is some data coming up for BTK inhibitors for COVID. So any comments on that? I can see that you've answered in the chat, but just for everyone's benefit.
Sure. Yeah. So I think, with the ibrutinib, as you know, for CAR T cell therapy, ibrutinib is being studied and has been shown that it decreases the cytokine release syndrome. So based on the similar concept that it decreases the cytokine, it decreases the inflammation, there is some early data, both with ibrutinib and acalabrutinib, that it may decrease the CRS associated with COVID-19. And both these agents are now in phase 3 studies as per the press reports, for COVID-19, not for CLL, but just COVID-19 disease for cytokine release syndrome. And there was just recent blood paper a few days ago, I think from the Boston group, where they showed, I'm not sure how many patients, I think few patients, that maybe there was some protection of the lung injury associated with ibrutinib. So I think that all would indicate that ibrutinib may be a good agent to kind of study. I think there was some concern which I have heard, and again, I don't know whether that's really proven, is that with ibrutinib, as you know, with ibrutinib, if you're taking ibrutinib, there is less, I think, seroconversion for pneumococcal vaccine and other vaccines. So maybe there will be a less immune response to COVID-19 if someone is taking ibrutinib and it develops COVID-19. And then, risk with ibrutinib with bleeding and AFib and ventricular arrhythmias. So I think there are kind of pros and cons to the approach, but I think as a treatment modality for COVID-19, as I said, it's being studied, and Dr. Jagannath may have more input into that. Maybe they have used it. We have not used it at our center just because we haven't had that many patients in a way as a therapy yet for COVID-19.
So that's one of the randomized clinical trial ongoing. So I do not know because BTK inhibitor comes in the toll-like receptors, which are the initial viral responses, and therefore it blocks it. It comes after, it's not an antiviral agent. It reduces cytokine release. So it comes, you have to meet the criteria that the patient is hospitalized and now, requiring oxygen. So even the patients who are eligible is further down at level 2, not at level 1, somebody who has just developed COVID and, they have to have requiring of oxygen. And if it is getting increasing, that's where there is a series of study. As I said, there is an anti-GM-CSF, there is a tocilizumab or anti-IL-6 receptor antibody from Regeneron. They are all in phase 3 clinical trial. So yes, there are a number of studies out there, which was an incredible number of studies, I should say, and we have to see. We all thought that remdesivir came out as if it could be promising, but today I saw the news and remdesivir may not be all that promising. So, that's why phase 3 randomized trial is important rather than storing chloroquine at home, right?
Taken the name of chloroquine, I should ask, there are multiple people who have asked the same question. So in both settings, so places like Mount Sinai and places like MD Anderson, are healthcare workers taking prophylaxis with hydroxychloroquine or chloroquine? And are you starting these patients on hydroxychloroquine?
Okay, they are not on, nobody is taking, I don't have hydroxychloroquine at home, so there is no question of prophylaxis or anything like that. But have I given? Yes, when I said in the early phase in Mount Sinai, it was part of the thing. Once the patient got admitted with hypoxia, they did give chloroquine, 800 milligram, and hydroxychloroquine 800 day one, and then just 400 for 4 more days, and it was over. It's almost like the Z-Pack dosing. First day you double, and then afterwards it is just 4 more days kind of a deal. But we are also cognizant. That's why I said, when I said that, we have the chart, these are our patient, and the EKG is quite often available, so you can see the QT interval. So you don't automatically give hydroxychloroquine and Zithromax together, because QTC prolongation, patient may die, but may not have died from COVID. We may believe that the COVID is why they died, but it could be our medication. So we don't want to do any harm. So I have to say that. But where it'll hand, and I can tell you, between our president and our scientists standing next to each other, this whole chloroquine things comes up from time to time. There is no evidence yet.
Up this last question, where do you see the role of antibody testing from, let's say 1 month down the line in all these patients, and how often one should be testing these patients? Because majority of patients, if we talk about AML, they are inpatients. If we talk about ALL, probably there's for a significant amount of time they are inpatients. But for rest of them, they keep coming back for each cycle or in between. So what's the frequency of testing in terms of PCR or in terms of antibody testing would you recommend? And would there be a difference in terms of what treatment they have received, for deciding between these tests?
This is an interesting question. Again, you have to take a pandemic area, and then you have to go to a non-pandemic area and ask how they would do it. In pandemic area, I said, because the prevalence is so high, when we are getting back, we have to test as a policy before transplantation, before starting a new cycle of therapy, etc. It is very important for us to know the status of the patient who's coming into our environment and receiving chemotherapy. So we have made arrangement for patient to be tested, and how long, whether everybody needs to be tested. Even when our institution asked around, the feeling in the New York area is a little different. Everybody wants patient to be tested before they start a new treatment. But elsewhere, I find that if the patient has no symptom at all and is coming in, there is no need to testing, and also the availability of testing. So in Mount Sinai, because it is done in the institution itself, so little more goes in how people will reply to it. So that's about the virus testing. But viral testing is definitely useful. The second one is the antibody testing. We are doing antibody testing serially, because we have a clinical trial to do convalescent plasma of people who have recovered, if they have high titer. Then we are getting their plasma to give it to the patients who are being treated, who are getting admitted now. So there is a convalescent plasma protocol. So that has mandated all of us ask people who are otherwise healthy and could donate blood, not myeloma patient. Okay, so myeloma patient I tested to find out what happened, but not cancer patient, the healthy patient who came and got admitted. And when they are released, many of them are requested whether they would volunteer, and many people do volunteer. And we are using that convalescent plasma to give it to patients who are getting sick in the hospital. And whether that would be effective, not effective, whether the antibody, serum antibody plays any role at all, again, no comment. I'm not saying that this should be done, but that is being done, and that's why we test a lot more.
Manju, are you there? Hello.
Vikram, it's your job now.
Okay, no problem. I thought I'm not sure if Manju is there or she's gone up, but anyway. So I think we'll close this webinar. I just want to thank everybody for participating. I just want to say that a big thank you to all the HCC members. I just want to say to all the people who are attending this that the slides and talks with the permission of the speakers will be made available on the HCC website, so you can always go back and use the material to help you. I want a big thank you to all the speakers for taking the time to do this. It's late night for them, all done at short notice. We're very grateful to you. I want to thank a few people in the background who have done a lot of the work. Our CEO, Bhavisha, she's put in a lot of effort. The team of Dr. Vinisha Pujari and team at NCG who have helped host and organize this. My co-moderator, Dr. Manju, has put a lot of work. The Soho team and the NCG team, and finally ICE, the team of ICE, Mr. Balamurugan and Mr. Arun Pratap Singh for getting a lot of the work done. Again, thank you all for participating, and hope to have a few more sessions in the future along these lines. Thank you all. Good night and good day.
Thank you very
Thank
much.
you. Bye.
Thank you.
Thank you.
Thank you.
very
Bye.
much.
Stay safe.
Thank you. Bye.
Thank you.